continue to log in. Thank you, everybody, for joining. My name is Allison Hall. I'm in the School of Health Professions, and I'm one of the co-directors for the core. And welcome to our third in a series of March talks on the learning health system. And we know for the last 2 weeks, we've heard from folks who are outside UAB. And now we are going to hear from one of our own from within UAB. And Aaliyah will sort of post in the chat as well. We've got 2 more upcoming sessions, both that sort of are focusing more on UAB. Next week, we will hear from a set of panelists who have been working with the COVID core about their research. And Mike Mugavera will talk about the impetus for forming the COVID core. And then the following, on the 31st, we are going to talk about what a learning health system should look like here at UAB. A small subset of folks have been gathering fairly frequently to sort of think through what are some of the core pillars or defining aspects of a UAB learning health system. And we are going to invite the entire campus to sort of come in and hear, and there might be some interaction as far as that's concerned. But for today, I'm going to turn it over to Pat Patrician, who is a professor in the School of Nursing, to introduce today's speaker. So Pat, please go ahead.
Thank you, Allison. It's an honor for me to introduce to you Dr. Shea Polancich. She's an improvement and safety scientist and has been practicing in this area of quality and patient safety for 2 decades. She is currently an associate professor and assistant dean for quality improvement and innovation at the UAB School of Nursing, with a primary practice setting at the UAB Medical Center. As a director in specializing in improvement, safety, innovation, and analytics. She is also the associate director of the core. Formerly, her roles included the director of quality and patient safety at Vanderbilt University Medical Center, director of data analysis and measurement at Texas Health Resources, and an NIH/NINR research intern, and health policy fellow at George Mason University. So let's hear from Dr. Polancich. Thank you.
Thank you, Dr. Patrician. I appreciate that very much. So I am going to quickly go ahead and transition into the presentation simply because I have a lot of slides and I'm not going to get to them all, but I'm going to do my best to go through this presentation and talk about a specific example of improvement in the learning health system with a case study of pressure injuries. I've done this presentation before, and as you heard over the last couple of weeks, you kind of have this different system level view of things, and that's what I'm going to call it. The presentation started out from a real broad and global perspective with Dr. Friedman, who really talked about the learning health system from a very broad, sort of conceptual kind of way. And then we moved into Dr. Rothman's presentation from Vanderbilt, and I'm very familiar with Vanderbilt, where I wouldn't say that it had some broad concepts or connections to it, but it had more of a sort of what I would call a meso, if you think about systems, a meso level kind of approach to it, because you talked about some very specific examples around population health, and then some other more specific examples with different opportunities from the Vanderbilt perspective. And then this presentation is very micro. It is really at that level of a project within a health system that bubbled up to what I would call really that learning community of people who came together for a very specific really opportunity for improvement within our health system. So I'm really not going to go through these presentation objectives. It really is to look at the concepts of a learning health system given a very specific example of pressure injuries. So I'm not going to ask you to take this opinion poll. Sometimes when we do this presentation, I ask people to do that word cloud. What is a learning health system, and what are the characteristics that define a learning health system or learning community? And you've heard different people's views of that from the last couple of weeks. But really think about that as we go through this presentation. And at the end, we may have a little bit of time to talk about that specifically for UAB. So I have some definitions that I sort of gravitate to for learning health system. One is the AHRQ, or the Agency for Healthcare Research and Quality. Their definition of a learning health system is one in which internal data and experience are systematically integrated with external evidence, and that knowledge is put into practice. And as we go through this presentation, I really want to see if you believe that what we've done with this example aligns with these concepts, because specifically, the result of this is that patients get higher quality, they get a safer environment, more efficient care, and the healthcare delivery organizations become a better place to work. So the learning health system model from AHRQ have these like sort of aspects to it that I kind of want to talk a little bit about. And I want you to think about this slide as we go through the example. They have leaders who are committed to the culture of continuous learning and improvement, systematically gathering and applying evidence in real time, employing IT methods to share new evidence with clinicians to improve decision-making, promoting inclusion of patients as vital members of the team, capturing and analyzing data and care experiences to improve care, and continually assess the outcomes and then refine those processes and training to create a feedback cycle for learning and improvement. And I really like this definition. So as you think about the example, think about each of these bullets, and at the end, maybe we can talk about how the project aligned with these. There are other definitions I just wanted to quickly put up. There's an IOM definition that I like as well, but it is the very specific of this that I like was you have to really understand the underlying improvement efforts behind the scenes that go on in the organization. That's the critical part of the healthcare system transformation and learning. And so these are some of the characteristics from the IOM. Now, I as an improvement scientist, I'm going to say that the reason I kind of talk a little bit about methodological frameworks for improvement is because as we did this project, we really grounded in the sciences. So there are always scientific underpinnings to improvement work. And I really just wanted to make sure that everybody is aware that the model for improvement and really began with the scientific method. It is the underpinnings, the foundation for improvement. But as you do improvement, there are also other sciences that you have to integrate. There's improvement in safety science, which that really is our foundation for the work of this project. There's dissemination and implementation. There are sciences to how we implement, how we spread innovation, and really even the work effort that we're doing. And then there are methodological frameworks that were developed specifically for improvement. The model for improvement is my go-to. It's probably the most simplistic, but it is really the foundational model that was the underpinning for Lean and Six Sigma. So all of those were really the sciences that we used to improve. I am a fan of Shewart. Shewart really was what I consider the father of the modern day PDSA cycle. Deming was one of his students, and he took it and really developed that PDSA, which is what we use a lot of times in the improvement world, that plan, do, study, and act component. So as we go through the example again, we're going to talk a little bit about that. But I wanted to make sure that also there's an understanding of the other theoretical models and theories that are important for how not only you improve, but how you learn. Improvement is critically, you have to have other aspects to improve. Change theory is very important from a perspective, is your culture ready for change? If that is very important to really beginning the process, do you have a culture that is going to support that? And leadership. There are two things about this presentation that were also very important from the work that we did was really the change, were we ready for it? And we were. And then leadership, do we have great leadership behind it? And so both of those things came together. And then I am biased a bit, and we'll talk a little bit about some of the use that I have for some of the improvement really theorists that we use particularly from my perspective, but do we really use all of these in practice? And do people really use all of the underpinnings, conceptual ideas, and does this produce learning? Well, I hope you will see that through this process, it really does. Now, how do all of these things come together to create that learning health system environment? We have experts who every day come to work and they do improvement. There are experts who do implementation. There are experts who have dissemination backgrounds. There are experts in research. And then we have those daily operational practice individuals who every day come to work and that's what they do. And I believe, this is just my thoughts about the learning health system or the learning community, that all of those things collide. That a byproduct of our work is that learning health system, that everything that we do daily together comes together to be, on a collision course to create learning health system. It's a byproduct of our work, not something that's in addition to it. So the things that we do every day will come together to create these learnings. So our pressure injury example that I'm going to go through and then give us maybe some time to talk is, we really began this, the context and the philosophical underpinnings that I kind of typically use is, if you can't describe what you're doing as a process, you don't know what you're doing. That's something that as we began to look at some of the things that were going on in our operational world, could we really describe our process? There are other things about it, really the ultimate purpose of collecting our data was to provide a basis for action. Did we have a basis for action based on the data that we had? And that was another little challenge that we were seeing. So we took some of these thoughts and then we framed the work that we were doing on the model for improvement. As I said, I'm very simple, okay? I need something that's very simple to sort of guide me in the way I do improvement. And so the model for improvement based in the sciences is really a great model for me to use. And so we framed the work that we were doing on these 3 guiding questions: what we were trying to accomplish, how we know a change is an improvement, and then what changes can we make that will result in an improvement. And we did really these continuous or iterative PDSA cycles. Okay, so that's kind of how we focus this project. I am biased toward Donna Bedian. I like to look at projects from the perspective of the structure that we work in, the process that we work in, and how are we really going to measure and evaluate. So we really have to look at measurable outcomes. And so that was really the framing for the work that we did. Now, as we began to look at pressure injuries, one of the key aspects of, again, from an improvement perspective, is to really benchmark yourselves against some national comparison and the literature. So what was the literature telling us about pressure injuries? They're significant, they're devastating, they're an adverse event, especially for the hospitalized patient. Our ARC researchers estimate that about 2.5 million patients annually are impacted by pressure injuries that are hospital acquired, and 3.5 to 4.5% of pressure injuries occur in the hospitalized patient. We spend a lot of money on pressure injuries. So you think about ROI when you think about learning and improvement. You think about the return on investment for the things that we do, and our expenditures for pressure injuries in the United States is about $9 to $11 billion annually. CMS actually has now considered pressure injuries or hospital-acquired pressure injuries at a stage 3 or above to be what are called a hospital-acquired condition, because of the financial impact and because they believe that most pressure injuries are preventable. Now, my wound ostomy continence nurse friends will say most, okay, because there are times that there are situations that maybe some pressure injuries are not preventable, but can we prevent them from being extremely higher in the staging? And I think that is true. But we looked at the external world and then we said, what is our internal opportunity? How do we compare? What are the things that are going on? And in 2016, the counts of our all-stage hospital-acquired pressure injuries at UAB was as high as 2,000 a year. And before anybody gasped, yes, that was what we were getting on our reporting. our nurse managers actually came to our chief nursing officer and said that, first of all, we are looking at this retrospectively. Our data is delayed. It's not real time. We're looking at it almost a month and a half behind, and we believe those numbers are erroneously inflated and inaccurate. And so there was a decision to be made. And when you think about all those theories and concepts we talked about, from a leadership perspective, the CNO had an opportunity either to listen to the leadership that she had or to dismiss the claim. And our CNO at UAB is very proactive and is a listening leader and said, yep, I'm going to take a listen to these leaders and see what we can do about it. So we evaluated that claim by analyzing data related to pressure injuries, really validating at the staff level on the nursing units, the competency of the staff, and then the documentation process, and then really looking at it from how do we compare what our staff nurses are doing with our expert wound ostomy continence nurses. Now, at the time that this was being evaluated, our data came from the nursing documentation. And we'll talk a little bit about how that was changed. So what we wanted to do was really at this point was to design a pilot. So we thought about that systematic approach to how we evaluate opportunities. And we integrated what was called the clinical nurse leader role. These are master's prepared nurses who really focused at the microsystem level, microsystem improvement. And we took two and put them into two units that were high or opportunity units for a hospital-acquired pressure injury. One was a ICU and one was a med-surg unit. And we did an improvement of design. And we used the clinical and an academic practice partnership where we brought in faculty from the School of Nursing who had expertise in improvement science with experts at the bedside and in leadership in nursing. And we said, let's look at this and see what we can do and see what we find. All of this kicked off about a 4-year series of improvements, and we'll talk about it. This is basically our timeline from that one little pilot that we got feedback from our nursing leaders to look at these data. And this is what we've gone through. So we're going to talk a little bit more about that. But the pilot outcomes, we found out a couple of things. We found out that our electronic health record functionality was creating a barrier to our reporting, meaning because we were looking at it retrospectively, once the chart was closed, we weren't really able to identify when revisions were made to our documentation. So for example, if a staff nurse had stated that there was a pressure injury at a stage 1, and then our wound ostomy continence nurses came back and deactivated that, and so that's really not, that's dermatitis related to incontinence. Both of those rows would be in your in the documentation. So a row would be in the documentation for the stage 1, and let's say that, let's say it was a stage 2, and then our wound ostomy continence nurse came back and said, no, that's really a stage 1, or it's something related to incontinence. We couldn't take that one out and say, okay, it's now been deactivated. It was still capturing the row where the original documentation was at. So all of this was actually creating a flawed, inaccurate reporting, really inflating our HAPI count sometimes three times. So let's say that stage 2 was there and our wound ostomy continence nurse said, no, it's a stage 1, it would capture both records. Okay, so that was really what was happening from that retrospective design. So the pilot study really confirmed the inconsistencies and the variations in our reporting of hospital-acquired pressure injury. And it kicked off our first learning that we disseminated. So we actually took this PDSA framework and that CNL pilot, and we talked about pressure ulcer reporting at that time. And as you can see, when we compared our CNLs who we trained to be the experts at wounds, so we took them, put them in these 2 units, trained them with our wound ostomy continence nurses, and said, you're the experts, okay? You're the experts. You're going to go behind staff nurses on these 2 units for a couple of months, and you're going to tell us if the competency of our frontline nursing documentation is high enough for us to be confident in the results. And what we were seeing is that sometimes it was 50% off, meaning our clinical nurse leader documentation, we would have 8 pressure injuries, and our staff nurse documentation would be 16. So between 30 and 50, well, 20 and 50% of our pressure injury, the total 33%, 20 and 50%, we were having some discrepancies. So we found out, yes, we did have some challenges with the documentation of our pressure injuries, and it was sometimes 50% inflated. So what did this outcome result in? Well, our iterative improvement cycle said we've got to really do something here. So we kicked off an interprofessional skin team. Now, this interprofessional skin team truly is interprofessional. We took all of the different groups that were working on skin, and we said we need to pull these groups together, create one group that has an interprofessional roster that we can really drive our improvement around pressure injuries in skin. Okay, so the interprofessional skin team, I initiated that, but it was immediately turned over to our operational experts. We have a physician who is the medical director of our wound ostomy continence team, who actually leads that with one of our wound ostomy continence nurses, who is now in the Center for Nursing Excellence with a focus on pressure injuries. So we pulled together all of the different groups in the organization. We have nutrition, we have PT, we have respiratory therapy, all those different groups that really, we have IT, we have coding, that have some sort of aspect related to pressure injuries and reporting of pressure injuries to really drive our improvements with hospital-acquired pressure injuries. And so this group came together. And the first year that we organized, our goals were really to say, we really need great data. Okay, we need great data to tell us that, number one, that our documentation is accurate, and that what we have from our reporting perspective, we can use to improve. So our goal was to create an internal really process, not only from our workflow that would give us better data, but that our data and reporting analytics stream was accurate. So that was our first goal. And overall, our goal was to decrease the number of hospital-acquired pressure injuries. Let's never lose sight of the fact that our technology and our improvements were really to drive improvement in our outcomes. So we redesigned our workflow, and we pulled in our technology to sort of help us after we redesigned our workflow. So what did we do? The first intervention was that we created where we have a workflow now where our wound ostomy continence nurses are able to stage all of our pressure injuries. Now, let me tell you, that was a lot of things were going on at the same time. And as we were developing the interprofessional skin team, the organization also committed a lot of resources to the wound ostomy and continence team. Okay, we went from 4 wound ostomy continence nurses to 12 who were certified. We added a physician medical director, and we have a nurse practitioner and a couple of wound techs. Okay, and that expanded our resources to give us an opportunity to create a really great workflow redesign. In the initial phases when we started this, our wound ostomy continence nurses were only receiving consults for stage 3 and above. And so we were using our bedside nurses to state or to describe pressure injuries we described that would be mapped to what we would consider the appropriate stage. And as we found from our pilot, sometimes that competency was not there with our staff nurses. So this expansion of our wound team gave us the opportunity to say, we can make a really great workflow redesign and have our wound ostomy continence nurses to be able to stage all pressure injuries. Okay, we went from a 1 to 300 bed oversight by our 4 wound ostomy continence nurses to a 1 to 100 bed, and we added a physician and a nurse practitioner who could debrief at the bedside and do some of those things that would allow us to really proactively manage our skin. We also, after we made that workflow redesign, we created 2 technology interventions to improve the accuracy and timeliness of our reporting. Now, you remember we were doing things retrospectively. We wanted to get to as real time as we could. So we had two. Now, if you're a clinician at UAB, the rounding checklist has gone through multiple iterations and multiple names, but you'll know what it is when you see it. We created this. We created a pressure injury component in the rounding checklist, and we created a HAPI analytical tool. Okay. So what we did was the rounding checklist is a custom built application in our EHR, and it highlights the existing clinical risk factors for certain things like central lines, Foley's. It's sort of a checklist that you can go in each day and say, I really need to check on this aspect of this patient's care. And so we added pressure ulcers or pressure injuries to this. Now, pressure ulcers was the old term. You'll hear me go back and forth. Their new terminology is pressure injury. So, but certain reporting structures still use pressure ulcer, but pressure injury is really the most appropriate terminology right now. But we wanted to get to real-time documentation and then really wanted to get to as close to real-time reporting as we could. This was an initial view of what it looked like when we added pressure injuries to this. And you will see right heel pressure ulcer red tissue superficial. What this will tell us is that our wound ostomy continence nurses used to go in every day, and they can use this tool, but they would go in every day and they would have a list of patients that they would need to see. Well, what this did for us with this new technology innovation was real time. When a provider actually documents, they can see the documentation. And this particular terminology, pressure ulcer red tissue superficial, means that a nurse has evaluated and observed this particular skin event, and now are saying, this is what I see. Okay, so this observation. When you see something that says stage 2, that means that a wound ostomy and continence nurse has come behind and actually staged this pressure ulcer. So from a real-time perspective, our wound ostomy continence team can log in, see their panel of patients for their unit, and they can say, oh, I see, if I only see this pressure ulcer red tissue, I need to go and stage that particular skin event. So if they see stage 2, it means that somebody on the team has actually staged that. So really great, in our workflow, it gave us a real-time view of our skin events. So what does that do for us for reporting? Well, we did two things. First of all, we had a section in our Cerner system where our pressure injuries are observed by our nursing staff and then documented. And then we had a specific section for our wound ostomy continence nurses who would go in and they, have their own section that we had the staging. But we added one thing called no pressure ulcer, meaning how could we capture out of the information that we had on the backside that there was not a pressure ulcer? That was one of the problems we had. So we added this documentation and it helped us to pull things out in reporting. Okay, so what did all this do and how did we actually use that to improve? We created a HAPI analytics tool, and we used a business intelligence platform through what was called McKesson. I think it has a different name now, but we used a business intelligence tool, and we focused on the incidence of pressure injury and incidence density, meaning how many do we have and where are they, both anatomically on the patient and the location of the patient, so that we can make real-time improvement in our organization. And we utilize that revised workflow where we have our WOC nurses who are now staging all stages. And that allowed us to have probably one of the few organizations in the country that have WOC nurse all stage pressure injury data. Okay, so we harvested that. And this platform allowed our users at the front line, those nurses who said, look, we don't have the data to really proactively tell us when we need to make some changes. It was too retrospective. Now our users are able to log into the platform on a daily basis, and they can see our reports on their unit. And we'll look at a few of those. The reporting tool has gone up in the number of reports that we have, but initially we had 7 pressure injury reports that were based solely for internal improvement, meaning they were designed to help us improve, to see real-time data on our patients, etc. 6 of the 7 were specific to the incident and the incidence density that we were talking about. And then we have a seventh report that's called the ARC HRQ PSI-03. The Patient Safety Indicator 03 is really specific to pressure ulcers, where we can look at our external data and see sort of how it tracks with our internal data. Now, they have different operational definitions, so we're not able to just compare and say, yes, we see this many stage 3 and above, and HRQ report says this many. This has a very specific definition used through Vizient. And so we actually, though, are able to see the trends and patterns in our internal data, and then we can actually trend and pattern what we're looking at with PSI-03. The good part about these data is it does have individual patient details, so we can learn from the patient. We can learn exactly what went on with that patient. So every patient, we can flow through the hospital and what happened to them from a skin perspective, staging, etc. But our initial front screen is this one. We are working on this, so it's really sort of SPC-ish. Right now it's at standard deviations, which is not exactly what we want, but the tool has some limitations on our SPC that we're kind of working through, and we actually transfer this to SPC. But we can see every month and all of our units, and we can go across from a total perspective of the total number of hospital-acquired pressure injuries, as well as the unique patients that have had pressure injuries. This actually gives us staging and how we trend on staging. We have different reports on different aspects of our incidents, and we'll talk a little bit, well, we're not going to go through a lot of detail on that, but our incidents, we actually have added for anatomical locations. So we wanted to see specifically where our patients were having skin events. So lots of information was available now to our frontline team. Now, we talked about outcomes. What did this do for our outcomes? So following the implementation of our technology and our workflow interventions, our total counts of all stage HAPI, we started in March of 2018. That release is April, but March of 2018 was our baseline of 164. Our most recent data that we have for February of 2021 is 34. So we went from a total of 164 a month down. This is our lowest number to date, 34. 79% decrease from the baseline. And then our SPC helps us to look at our shifts. We shifted our process once in November of 2019. And then we are looking at that again, and I'll show you what that looks like. And we've had no reported data discrepancies by our nursing leaders or our wound team since May of 2018. We spent 3 months validating that our data were accurate. And so this has been a great win for us as well. Our PSIO counts, we had a large decrease. We were up in the really, I think in the 20s per month. We were about 5 to 6 standard deviations above our peer comparators, and we've done a lot of work on that. We've had a slight uptick, but it's on a downward trajectory. So we'll look at those in just a moment. So this is our all-stage hospital-acquired pressure injury. You will note we started at 164 in March, and as we made those changes, we had a shift downward. This was actually where we saw our first downward trend, and now we continue to go in this downward trajectory. This has been a great win. This was during our higher COVID numbers, where we had a lot of patients, and we had some COVID challenges with proning and things of that nature. We'll talk a little bit about what we did here within these months, but really a great win for us over this time period. Our PSI-03, as I talked about, has seen some really nice downward shifts. Again, we had some upward trends. Again, we had a large number of patients in our hospital with our COVID challenges, and we'll talk a little bit about, again, where we went with that, but seeing some good results there. So our technology innovation, did we learn from it? Yes, we did. We learned from this innovation and said, we want to take this technology and let's transfer it intra, and I guess that's sort of an intra project. We built a second platform specific to perioperative services, and we replicated the same tracking with our revised workflow and technology, because we knew that patients were having pressure injuries post-procedure. And before we had this, that we could connect our one of our perioperative quality managers was just having to call and having the units to tell her if there were pressure injuries post procedure. But now we're able to look at that also on a real-time basis. So what we did was we connected our perioperative data to that and to our HAPI analytics tool. And we have a lot of the same types of reporting, but specifically for the different the surgical departments or teams, et cetera, and how we can look at our pressure injuries post-procedure. From that, again, we said, okay, we need to continuously learn. Is there some research that we can do as we began to develop our reporting and look at the very specifics of our patient populations and where our pressure injuries were occurring? So we instituted a HAPI Hill study. And so we wanted to actually we did it from a retrospective design where we said, okay, we already have some things that we're using for our pressure injuries. And we want to see if that really works on the heels too. So if you've all seen the Metholex, the silicone adhesive dressing that people use sometimes on the back or on the sacrum, we said, let's see how this works on the heels. And so we implemented a study in February of 2020, and we initially started with 3 ICUs, 1 intervention unit, and 2 controls. And we saw some really good results. We saw out of 47 patients who we had criteria for having use of the Metholex in those units, 0 patients during our time period had a heel pressure injury. So we said, wait, let's see if we can expand this a little bit. So we currently have over 300 patients. Around December, had over 300 patients that were in this study, and we've only had 2 pressure injuries during this time frame, a 0.7% rate. So we're meeting this month, actually tomorrow, to evaluate the financial return on investment for this with our vendor, who has done some of these studies with this Metholex dressing. But as you see, we continue to use our data to help us to identify opportunities to improve and to learn from this. So really, future improvements are our next steps. From the learning organization perspective, we wanted to say, how do we build our competencies, not only with our staff, which our wound ostomy continence team did a great job of now being able to educate staff, our staff nurses, build that competence with our Center for Nursing Excellence, to really have our get the learnings from that, from the work that we did. But we also wanted to go back upstream. How do we go, and from the academic and practice perspective, how do we take our learnings and go back to how we teach and train students? And so we wanted to build competence within our educational process. So we developed training very specific to pressure injuries within our School of Nursing clinical experience. In the summer of 2020, when we weren't really able to have a lot of students, many organizations had to close off from having students, we were able to allow our student nurses to come back into the organization with a very specific focus on quality and safety rounds. And we very specifically had training from our wound ostomy continence nurses to actually go and help our students to really use the clinical experience to understand how to best manage skin. So a lot of work building that back upstream, and we utilize the expertise of our WOC nurses for teaching skills in our pre-licensure courses. And we're also developing the Wound Scholars program within the organization to develop that expertise on the units. So a lot of the learnings told us we really needed to have more expertise on our units. So futuristically, from a research and dissemination perspective, we have developed a cost of quality model. This one was actually published back in 2020. It was one of the few that has really, from a perspective of having accurate WOC nurse staged data, where we compared cost of patients with and without pressure injuries. This is no longer in press. It's actually been published, so you can actually go see that UAB has one of the few models based on that. And then COVID research and our HAPI. Learning during crisis, we used our data from our real-time reporting or our daily reporting that we were able, this was accepted for publication in March of 2021, from the Journal for Healthcare Quality, where we identified that because we could actually go, we have a specific nurse in the Center for Nursing Excellence who can do what we call the root cause analysis on pressure injuries from our data that we have. We found out that quickly as we were watching COVID numbers, that we were seeing upper body pressure injuries from COVID with proning. And so we were able to quickly make some changes on that. This one is actually coming out, and I'll show you what those data look like. We have a second publication that's in development, and we're about to submit on regression modeling to see if we can identify at-risk patients, where we can try to figure those out with our COVID patients. So this was a very specific core COVID research team that came together, and what we've done with that. We also built into our educational system the use of our Doctor of Nursing Practice CRSRNA students who are looking at non-hospital bed surface time to see if downstream the different surfaces prior to surgery are creating opportunities for skin events. So lots of things going on, and we have a smart care proactive risk dashboard that we created out of all this. Our COVID learnings, just quickly, you will notice that we had some our COVID patients that had HAPI, and our total HAPI numbers and our COVID patients, we saw the same type of pattern. And what we did was we found out that in May and June, when we started evaluating for those proning patients and using the Methylex dressings on the face and neck, that we had great learnings. And so our staff nurses, you have to give kudos to them who were observing things in practice and saying, okay, we really think we're seeing things on the head and neck and from the proning process. We were able to quickly make some changes, and we saw this decline again. So lots of great work there. But from a discussion and conclusion perspective, UAB, we think, is leading the way in pressure injury improvement efforts. So this group of people that were interprofessional that came together around this particular opportunity is its own learning, own learning community. And what we've done is we are now leading the way, and we are actually helping other organizations to sort of develop this type of process. We actually met with one last week. Our woundostomy nurses have some of the very, I would say, in the country, there are probably only a few organizations that have confirmed HAPI in real time. And we've implemented our changes based on actionable data. So we have event review processes, not only from our pressure injuries in our inpatient units, but also PERIOP. PERIOP did some great work, focused their intervention based on some things from the devices in the OR rooms. And we have been really focused on heels and buttocks when we found out that these were areas that were very specific to our organization. We have disseminated 3 publications, now 4, and 3 national presentations in that 3-year time span. And we've been working on several grant opportunities. So from an LHS perspective, what are the implications? Learnings have been translated to other clinical issues. We can use this same process and have been using the same process, very data driven. If you think back to that slide where AHRQ said, these are all the different things that help a learning system. I hope you've seen those in alignment with this project, but how we actually build other projects within the organization. We've replicated some of these processes, and we will continue to replicate that. And this has all been a byproduct of the operational improvement, meaning something that we saw in the operational world. How did we bring all the different other aspects together to collide to create learning, just from a byproduct of our operational improvement? It's not been something else. It's been how do we pull everything together? And then we added different aspects of it as we iteratively improve, basically, those COVID learnings. So pressure injuries are just one example of our LHS work occurring at UAB. It has an interprofessional component, intraprofessional and interprofessional component. We have looked at it across nursing, but we also have a very large interprofessional collaboration with our different stakeholders and our interprofessional skin team. So the implications are there to look at this, really the model for other things. So as I end this and take questions, are there examples of LHS efforts that you can discuss? And is UAB positioned to be a LHS or a learning health system or a learning health community. And that will be something that we can talk a little bit about, but here are some of our references. So quick presentation, sorry, I went really fast, but I did want to leave some time for any discussion and really talk about what you think is going on at UAB.
That was wonderful. So thank you so much. Are there any questions? Feel free to put things in the chat and I can read them out, or a hand is up. Is there a hand up? Let's see. I'm looking at my screen. If not, I do have a quick question. I can sort of bounce it off first. Shea, I was struck at the very beginning of your presentation when you sort of laid out all the things that we could do and sort of say they would sort of add up and we would have a learning health system. That sort of initial slide. And I'd like for you to speak a little bit about intentionality, if you will. It seems like you are very intentional about using the quality improvement practices and then disseminating certainly beyond our walls. But how do we think about intentionality in terms of spreading learnings similar to what you've done, both internal and external to UAB?
Yeah, so I think in my mind, as I was thinking about this, and I was talking with some of the other individuals who were actually on this presentation, that a lot of things are going on right now. I mean, currently, I mean, even, and I see Dr. Buckhalter is on here too, the things that we do in our normal everyday improvement cycles, in our normal everyday educational programs, these things are already occurring. Okay, and so how do we pull the alignment together? So I think about projects that are going on right now, not only in nursing, but specifically from a COVID perspective. That was one of the things that really caught my eye as I was on this COVID research team. There are so many different things that are going on in the organization that people are doing daily, okay? And I think the intentionality is how do we align those? And I think that's what you're doing in the core by bringing in the concept of the learning health system and how do we begin to build towards that. So I think it's how do we pull the people together from the daily work that they do and see it and frame it from the perspective of this is a component of us as a learning health system. And I think that's what these different presentations have done, and what our last presentation may be getting at of how do we pull those things together at UAB. So I think intentionally we have to raise the awareness of our the people who work at UAB, whatever they work in. And I'm not saying this is just the medical providers or the providers in the front lines. I'm saying everybody can have an opportunity to be a part of our learning health system model. So I think we just need to raise, intentionally, I think we need to raise the awareness of where we're at UAB from all of our perspectives.
Thanks. Others, thoughts, comments, reactions? Jump in.
Allison,
Scott, yeah.
let me just piggyback onto what Shea just said. You guys are familiar with the patient safety data that sort of says, for example, when you use the IHI trigger tool, just an intentional method of routinely looking at charts and looking for markers of potential events. Not that that's exactly what we're going to do, but when you do that, you find 10 times as many patient safety issues than if we just wait on individuals to report those through Trend Tracker or some other mechanism. And I was thinking, as Shea was talking, in our learning health system endeavor, if we want to make it possible so that folks can report their QI projects and the things that they're doing to improve. But even more than that, or beyond that, if we intentionally create a mechanism to look for and collect that information, beyond just encouraging folks to report things, but create a tool. And I don't know what that is yet. It's easy to say and it's hard to do. I would bet you there are large amounts of learning and things that have gone on in all of our different areas that we could bring together. I think that ought to be one of the things that we pursue as a learning health system.
I also think that, I guess in a way, I'm struck by the things that I do from an academic perspective, but I think we need to bring the other pieces to the operational environment, not the other way around. I mean, I think of myself from the research side of me, and I'm saying, do I start on my research side, or do I come to the operations and bring the others to me? And I think all the work that we do operationally lends itself to having others join in. It's just harder for the operational side to say, oh, let me get an academic partner, let me get a research partner, whatever. I think it needs to go the other way. I think we need to focus on our operational care delivery and then bring the others to it. And I think, I don't know, I guess that's just a model that I think works a little bit better for the operational world, because they're, the operational folks are practicing. So I guess that's just one thought. How do we look at the things we do every day and bring the other pieces to it?
Mike, you are muted.
No, thank you, Shea. This is such an incredible journey and story. Thank you for sharing. So one of the questions, I know Allison has kind of been raising this as we've been talking about LHS the last several months, is the idea of this is an amazing journey and it spans so many different units, but sometimes we hear about, in one unit or one area, similar stories where LHS is being embodied and is happening. And I guess one of the challenges going forward or opportunities is, how do we amplify those messages for shared learning? Any thoughts you might have? So if one unit is doing something particularly well around a challenge that emerged and taking an operational approach and bringing in improvement science and studying and whatnot, any thoughts you might have from your experiences, here and elsewhere on how do we make sure that the knowledge is shared and not, left in one unit, but really kind of create this fabric so folks are learning from one another?
Yeah, I guess that is the harder part. I mean, I was at Vanderbilt too, and I was listening to Dr. Rothman's presentation last week. I think that is the challenge. Do you have people bubble up ideas to you, or do you look at system level priorities for the organization and say, how do we mobilize around these? Because I think about how we sort of started this. Okay, so how we sort of started this is what was keeping the board up at night. Okay, and from a nursing perspective, this was keeping the board up. Patients with hospital-acquired pressure injuries, patients with falls, or whatever that was. But we began a lot of this by saying the board is really concerned about our patient outcomes specifically to this. So I think a lot of the efforts that I've worked on here and in other lives, other professional lives, have been related to those clinical events that really were driving our, I don't want to say challenges or opportunities with our patients, because the outcome that we want to see is the best for our patients. So I think maybe it's looking at it from that lens of what is really, the biggest issue we have with our patients, per se, and how do we want to improve those? So I don't know. I guess that's just one thought. There are other thoughts about having people who have great ideas, because then you get people who are passionate about those ideas and having them bring them to you. But I think there's two sides to that. I think there's a side of what is really impacting our patients, and then who's passionate about something that improves our patient care and having those come as well.
That
and
makes sense.
I think I have a chat. Let me see. I think something. Explain the roles and the importance of system leadership in achieving and maintaining a successful learning health system. Well, yes, I can't stress enough the importance of system leadership, because our chief nurse was a part of the process. I mean, you can imagine the chief nurse who would go and sit in some of these meetings. Now, she didn't get to all of them, but would go and sit in some of these meetings and say, okay, I'm going to remove barriers for you to do this project because I'm going to support this. And I'm going to support it not only at the clinical operational group level, but also at a board level. I'm going to go and I'm going to say, here's what we're doing. And then you have the academic support as well. We have a very strong academic practice partnership where we had, resources given to faculty who had expertise in improvement and safety to help design, as well as a chief nurse who was really willing to go that extra mile and remove barriers. So Lori, to your point, you can't do anything without strong leadership because you have to have people at the table, not only to help you remove barriers, but to say, I can get resources for you when this occurs.
Susie, did you unmute yourself on purpose?
No, I wasn't unmuted.
Oh, okay, sorry. I thought okay.
I can
Sometimes-
follow. Oh,
Can
go ahead, Susie, I'm sorry.
Yeah, I would like to make a comment to this. Notice that Shea started out in 2016 and we're now 5 years out from this. I think some leadership support grew over that 5-year time. Would you not say that's true, Shea?
I'm sorry, could you repeat that? I couldn't hear.
I'm sorry, my mic was down. I think leadership support grew over the 5 years of this work so far. It was actually not top on the burner at first.
It did. I mean, the leadership support was always, there was always specific leadership support in certain areas, but as the process evolved, greater and greater leadership support grew. I mean, and it was not just from a nursing perspective, but it was broader. So, you would go and have board presentations and then you would get support behind the efforts that were there. So I will say that there was always some degree of support at least one high level nursing leader. And then from there, others came along and jumped on it. So as you continue the journey and you see good outcomes, which I can't stress enough about how you continually improve your outcomes, you get more and more support for that. So,
Mike, you had another comment?
I could just follow up, Shea. I think in thinking about how do we share some of the knowledge across? So the idea of like a dashboard, I've seen multiple units and groups develop dashboards, and I have to imagine there are certain stumbling blocks, challenges, lessons learned. So just trying to think about as we go forward, any thoughts you might have in terms of as groups are tackling different challenges with a similar process and products and things, just your thoughts on how we might share knowledge. Everyone is so busy, and you shared a beautiful story how to fit it into our work, how to make that happen. How do we do that across groups so that the next person creating a dashboard doesn't run into the challenges that your group ran into making your dashboard?
yeah, I think that is probably the data piece is the biggest sometimes barrier. Okay. And I will say that because it really sometimes is who that enables you to get the information that you need or to build or, have those resources to do it. The sharing across, there are multiple platforms that we have at UAB and all of them serve a good purpose. I'm not saying that they don't. I'm saying that I think that's one of the pieces that from the LHS model that I think we need to, and we've talked about this in some of our LHS meetings, is that we need to bring together, like, how do we communicate the best tool for the best project or whatever that is. I think a lot of times, and I'm going to be blunt, a lot of times it's who helps you the most in that situation, and I don't mean that critically. I mean, when you get somebody that has the opportunity and the bandwidth to help you, you often go to that person to get things done. And so I do believe that there is a need for that. I don't know that I have an answer to that, but I do know that there is a model for tools that is global, meaning you have to have patient level data. You have to have a tool that actually can help you do analyses that help you trend over time. And so there are certain characteristics I think that we can look at, but as far as across tools, I don't know that there is a one solution that people have at UAB. So that's just the, what I know at the moment.
All right. Anybody else? It's 1 o'clock. So, so thank you very much, Dr. Polancich. That was a great presentation. We're doing great things at UAB. So thank you for highlighting that. And stay tuned again. You all join next week, same time, same Zoom room. Take care.
Thank
Okay.
y'all.
Bye-bye.
Thank you. Bye-bye.